Hi, welcome to today's presentation on neurodegenerative diseases. In this session, we will explore the neuropathology of conditions that affect the brain and the nervous system, ranging from Alzheimer's disease to Parkinson's disease and beyond. So let's dive into the basic principles of neurodegeneration. Neurodegenerative diseases are characterized by gradual loss of neurons within the gray matter of the brain. This loss can often be attributed to the accumulation of abnormal proteins that can damage and ultimately kill the neurons. And there are several key regions of the brain that are affected by neurodegeneration. For example, if there's degeneration of the cortex, the outer layer of the brain, that is, it can lead to dementia, which is a condition that is characterized by memory loss, impaired thinking, and difficulty with carrying out daily activities. In addition to dementia, you have neurodegeneration that can also affect other areas of the brain. So, for example, degeneration of the brainstem and the basal ganglia can lead to movement disorders such as Parkinson's disease. So, in summary, neurodegenerative diseases encompasses a great range of conditions that involve progressive loss of neurons, and that can have significant impact on cognition, movement, and daily functioning. So here we have the most common types of dementia. So you have Alzheimer's dementia, vascular dementia, frontotemporal dementia, dementia with Lewy bodies, Parkinson's disease-associated dementia, Huntington disease, and mixed dementia. So we can't be 100% sure about the diagnosis only after the patient is dead and put his brain tissue under the microscope. There is not any definitive treatment to dementia. However, we can use medication that can boost cognitive ability of the patient, and this partially slow down the progress of the disease. But so far, it's impossible to stop the progression, you know. Okay. So here we're going to explore the pathological protein deposition in the CNS. These abnormal protein accumulations play a key role in various neurodegenerative diseases. So let us examine some examples of extracellular protein depositions. You have beta amyloid plaques, and these are deposits of beta amyloid protein fragments that build up between neurons, and these are basically the hallmarks of Alzheimer's disease, contributing to the progression of cognitive decline and memory loss. Then you also have prion protein aggregates. Prions are essentially misfolded proteins that can accumulate outside the cell. And in diseases such as Creutzfeldt-Jakob disease, these prion aggregates can disrupt normal brain function and lead to neurological symptoms. Then you also have alpha-synuclein aggregates that are found in Parkinson's disease and related disorders, and these abnormal aggregates of alpha-synuclein protein accumulate in extracellular matrix or space, forming structures known as Lewy bodies and Lewy neurites. These aggregates will then contribute to the development of movement disorders and other neurological symptoms that are associated with Parkinson's disease. These pathological proteins and their depositions will then represent important targets of research, as you can imagine, and also for the potential therapeutic interventions in neurodegenerative diseases. Now we will focus on some of the intracellular aggregates. So you have neurofibrillary tangles. So remember, the beta amyloid plaques are outside, and the neurofibrillary tangles are inside. So these are essentially aggregates of hyperphosphorylated tau proteins that are found in Alzheimer's disease. Neurofibrillary tangles accumulate within the neurons, disrupting their normal function and contributing to cognitive decline and memory loss. Then you also have tau protein inclusions, tauopathies, such as frontotemporal dementia and progressive supranuclear palsy. Are characterized by intracellular aggregates of abnormally phosphorylated tau protein. And it is these inclusions that contribute to the development of neurological symptoms that are associated with these conditions. So it's making a lot of sense now. And you have the intranuclear inclusions. Huntington's disease is actually, as we all know, a genetic disorder and is actually associated with intranuclear inclusions that contain mutant huntingtin protein within the neurons. And these inclusions then disturb the normal cellular function and contribute to progression of degeneration of the brain cells that are seen in the Huntington's disease. These intracellular pathological protein depositions highlight the diverse mechanism of underlying neurodegenerative diseases and provide valuable targets for therapeutic interventions, like I already mentioned. In Alzheimer's disease, it's similar. So you have it's characterized by progressive decline in cognitive function, including memory loss, like I already said, and also impaired thinking, and people generally just have difficult time performing daily living activities. The hallmark feature of Alzheimer's, if I have to say, would include the accumulation of two proteins. So that is amyloid beta and tau protein in specific regions of the brain. And these proteins form plaques and tangles, disrupting the normal neurological function, okay, and neuronal function on a micro level. These changes in the brain will also result in secondary effects. So that would be neuronal dysfunction, neuronal death, and subsequently inflammatory reactions. Now, when the disease will progress, these effects will contribute to the worsening of the symptoms of Alzheimer's disease and the decline in overall brain function. Alzheimer's disease is actually posing a significant challenge for individuals and their families. So not just individuals, but also their families. Please know that. And not just that, but it also puts a overall burden on the healthcare system, highlighting the importance of continued research and development of effective treatment. Vascular dementia. Okay, so vascular dementia is characterized by multifocal infarction and injury in the brain, typically resulting from microinfarctions that are mostly associated with conditions such as hypertension, atherosclerosis, or vasculitis. These vascular or vessel-related changes lead to cognitive impairment and thus decline. The risk factors for vascular dementia include hypertension, diabetes, hyperlipidemia, smoking, you name it, cardiac arrhythmias. These factors will contribute to the development of vascular-related brain damage and also increase the likelihood of developing dementia. Vascular dementia can also be associated with hereditary diseases, such as CADASO, which is cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. So cortisol essentially is a rare genetic disorder characterized by mutations in specific genes that are affecting the blood vessels in the brain, then thus leading to the cognitive decline and dementia. This then makes perfect sense because you need to understand the risk factors and underlying mechanisms of vascular dementia. Because it is essential for early detection and to prevent the condition in an individual, and also appropriately manage the condition in a particular individual. Lewy body dementia, okay, this one refers to dementia attributed to Lewy body pathology, so it's very self-explanatory. This pathology is in the neocortex and the limbic system of the brain. Lewy bodies, what are they? Are essentially abnormal protein aggregates that disrupt the normal neuronal function. One characteristic feature of Lewy body dementia is the onset of cognitive changes before or simultaneously with Parkinsonian motor symptoms. These cognitive changes may include memory loss, visual hallucinations, and fluctuations in attention and alertness. It's important to note that Lewy body dementia and Parkinson's disease with dementia are distinguished based on clinical criteria. However, pathologically, these two conditions cannot be distinguished, as both involve the presence of Lewy bodies in the brain. So you need to understand the clinical features and pathological basis of Lewy body dementia to understand and diagnose accurately the disease and appropriately manage this very complex condition. So we have frontotemporal dementia. It is characterized by disturbances in behavior, personality, and language. It is accompanied by focal degeneration of the frontal and the temporal lobes of the brain. These changes can manifest as alterations in social conduct, disinhibition, that is so important, apathy, and language difficulties. And gross pathology of this degeneration reveals degeneration in the frontal and the temporal lobes. That's very appropriately named. This degeneration may also actually involve cortical or basal ganglia and lead to their atrophy, but this can be symmetric or asymmetric. Also, substantia nigra depigmentation can emerge in a subset of cases that will further contribute to clinical manifestation of this disease. Frontotemporal dementia essentially encompasses a spectrum of clinical features and their underlying neuropathological changes. And understanding the complexity of this disorder is also essential for accurate diagnosis and targeted interventions to basically address the specific needs of affected individuals, like I mentioned for the others. In Huntington's disease, it's basically degeneration of GABAergic neurons in the caudate nucleus of the basal ganglia. This is a region of the brain that is involved in movement control and coordination. It's an autosomal dominant disorder, which is caused by expanded trinucleotide repeats, so CAG, in the Huntington gene specifically. And the expansion of these repeats will lead to production of abnormal Huntington protein, that then goes on to play an important role in the pathogenesis of this disease. Importantly, the number of CAG repeats can further expand during spermatogenesis, as I'm sure you all know. This is a phenomenon known as anticipation, and it results in earlier onset and more severe symptoms in subsequent generations. Huntington's disease basically presents with chorea, characterized by involuntary jerky movements, and that can progress to dementia and depression. Can be severely depressed, these people, you know. The average age of presentation is around 40, 45 years old, although symptoms can manifest earlier or later in life, you know. The age in which the symptoms first present is based on the number of repetitions, these CAG, in the Huntington gene. So understanding the genetic basis and again the clinical manifestations of Huntington's disease is important for not just like intervention and providing care for your patients, but also early diagnosis, because you're then going to improve the outcomes of the patient, you know. For Parkinson's disease, it's a relatively common neurodegenerative disorder, and it's characterized by degenerative loss of dopaminergic neurons in the substantia nigra, which is a region, again, of the basal ganglia that is involved in motor control and coordination. This disorder is related to aging, and it will be like seen in approximately 2% of older adults, which means, again, it's very, fairly common. It's not the exact mechanism of the disease is really unclear, but both the genetic and the environmental factors are believed to play a role in its development. The triad or the clinical features are tremor, rigidity, and bradykinesia. And then additional features would be postural instability and shuffling gait. So in tremor, you would basically have involuntary shaking or trembling of the hands. It can be of the legs, it can be of the arms, it can be of the jaw, or it can be of the face. So tremor of any sort, basically. And in rigidity, there's some sort of like stiffening or inflexible movement of the limb and trunk. So movement is generally hard and difficult for these patients. In akinesia, or better said, bradykinesia, you will have patients that have a reduced ability to start a movement. So basically, initiation of movement and execution of voluntary movements is hard. So they'd be really slow in their movements, which is why it's bradykinesia. Or sometimes they will even lack movement, which is why it's called akinesia. I also mentioned postural instability and shuffling gait. For that, the patients will have difficulty to maintain balance, and they will more or less like tend to shuffle while walking, and then these patients would be at an increased risk for falls. So as Parkinson's disease progresses, individuals can experience more symptoms, like their gait can freeze, or their posture would be like really stooped, or they might have cognitive impairment, which is like bound to happen. And again, understanding these things are important to correctly diagnose your patients and then start them on the appropriate pharmacological treatment. But also sometimes in Parkinson's, you can also give non-pharmacological interventions. to like generally improve the quality of life of these patients. Now we will delve into the histological findings that are associated with Parkinson's disease. In Parkinson's, histology will essentially reveal loss of pigmented neurons in the substantia nigra, which is, again, like I said, is a region that is associated with motor movements and movement control. So you will have round eosinophilic inclusions of alpha-synuclein that are known as Lewy bodies. And these Lewy bodies are going to be observed in the neurons that are affected. This is the pathological hallmark of Parkinson's. Dementia is a common feature of Parkinson's, but it's usually of a late stage Parkinson's disease. So the early onset dementia may suggest Lewy body dementia, which is like its own distinct clinical entity, characterized by dementia, hallucination, and Parkinsonian features. In Lewy body dementia, histology will give cortical Lewy bodies that we can use to further distinguish it from Parkinson's disease. And here are just the sources that the authors used. Please remember, again, I'm repeating it for the 6th time now, that understanding histological or clinical manifestations or features of these neurodegenerative disorders are very extremely important for accurate diagnosis. So then you can give appropriate treatment for these patients and also increase our understanding of the underlying pathology of these conditions.